Healthcare, where people are the heart of our business. All County Healthcare is a Medicare certified agency where one call will service all your home care health needs. For more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Hi, welcome to You and Your Doctor, where we're teaching you how to live a longer and healthier life. I would just like to say at this moment that we're sending prayers and thoughts out to our friends in all the Texas areas that were hit so badly by the Hurricane Harvey. We are keeping you in our prayers. We're sending you lots of energy and love and also donations. So our thoughts were with you. We are being presented by AMP2 TV and proudly sponsored by All County Healthcare, a Medicare certified home health agency, where we also are teaching how to live a longer and healthier life, where patients are the heart of their business as well. So we are streaming live right now on 1470 AM and 95.3 FM. And we're also on All County Healthcare Facebook fan page. So you can follow us there live. We're also on AMP2 TV and YouTube. So welcome. It's great to have you here this evening. We're here every Tuesday between the hours of 6 and 7. So if you have any questions whatsoever for our doctors this evening, please give us a call at 888-565-1470. Or if you have any questions for any of the doctors and or All County Healthcare, please give Maddie a call at 888-717-7170. She would love to answer any of your questions for you or get you in touch with any of our doctors. We also have the past shows that we have done archived on allcountyhealthcare.com. So take a peek on there. We have the experts here. So it is with great pleasure that I introduce you to our next doctor. And I was told that he is an absolute expert in his field. So welcome, Dr. Erik Beyer.
Thank you.
And you are a cardiothoracic surgeon.
That is correct, yep.
Excellent. Now, I was told he is the best in the field. Am I correct in that?
Well, we get very, very good results, and we're focused on patient safety and the results. So I'm very proud of the results that we achieve at Florida Medical Center. So, yeah.
That is wonderful. That is wonderful. And I love Florida Medical Center. That is a great hospital. I'm very familiar with it.
Thank you.
Yeah. So one of the things that I'd like to ask is, what made you decide to go into this particular field, or just being a doctor?
Yeah, that's an interesting question. Ever since I could remember, I have told my parents that I wanted to be a doctor. So it's hard for me to pinpoint exactly where that came from. But I do remember, very early on in life, going to the library and, back when you could check out books and stuff, going there and looking at all the different types of pathology books and doctor books. And I was always very interested in it. I don't know why exactly.
Amazing.
Yeah, my mom always tells me that. I said that from a very early age. So,
wow.
Yeah.
So what made you decide to go into this particular direction?
Yeah, that's a good question too. In medical school, once I was in medical school, I had the opportunity to be exposed to surgery, and I was exposed to pediatric surgery. While I was there, there was a nice surgeon that took me in when I was, my second year of training, and I spent a lot of time with him, and I thought, this surgery is kind of my thing. And then I did a general surgery residency in Houston, and I want to reiterate what you said. Our prayers go out to them.
Yes,
I still
absolutely.
have a lot of friends there. I lived there for 10 years, and two of my daughters were born there at the medical center. So, that's a big deal. And all those pictures, I know all those places that they're showing. It's terrible. But having said that, I did train in Houston. It was a great medical center there. And I did my general surgery, and I was exposed to open heart surgery while in training for general surgery. And I thought, wow, that's, I like this a lot. And so I went on to the Cleveland Clinic Foundation in Cleveland, Ohio, and trained there to become an open heart surgeon. And so that's kind of my history on that. Yeah.
Wow. Well, you know something, and I also know the Florida Medical Center has really amped up their cardio department.
That's
where
right.
They're it's amazing some of the things that they are doing when it comes to the heart.
Yeah, we have a hybrid operating room where we work closely with cardiologists doing combined procedures. They just opened up an electrophysiology lab that's state of the art for Broward County. And so, we have great electrophysiologists. I think you've probably met a couple of them along the way. Like Dr. Kenningsberg and Dr. Nayeri, and they're such a joy to work with, a pleasure to work with. It's nice having that nice collaborative approach with the cardiologist that I get to work with. So yeah, no, it's been exciting. Florida Medical Center was the first hospital in Broward County to do open heart surgery. And and so I think we kind of respect that tradition, and we're trying to get back on top of things and be the number one place to come to for heart care.
Wow, that's absolutely fabulous. Absolutely fabulous. So I read a little something about chocolate.
Yes,
and possibly wine.
Yes, red wine and chocolate. Well, alcohol and chocolate, believe it or not. Yeah, it's kind of a fun topic to talk about, and a lot of people are interested in it, which is nice. Yeah,
of course, it gives them permission.
Kind of a guilty pleasure. That's exactly right. Yes. And dark chocolate, 70% or higher. Are very rich in what's called flavonoids, which are big time antioxidant, which when it's circulating in your bloodstream is very healthy for your blood vessels. And so over time they've done many studies, and it seems to be bearing out that eating a couple ounces of dark chocolate every day is probably not a bad thing. In fact, I keep. It's funny if you looked at my cupboard, there's always at least 4 or 5 bars of dark chocolate, and that's kind of a little bit of my go-to snack. It's obviously a lot more bitter than milk chocolate,
but I bet it tastes great with wine.
And that's wine. You nailed it. That's exactly right. And so red wine is. It's funny. You'd be hard pressed to find a heart surgeon that doesn't drink some red wine. A lot of cardiologists do too. I know a few that own some vineyards, believe it or not.
Oh my gosh!
But yeah, they get that into it. But again, same thing there. The flavonoids in red wine seem to have a protective effect, and so 1 or 2 glasses of red wine in the evening is considered fairly healthy. Obviously, don't drive after that. But
right.
But
that's very interesting.
Yeah. And but it's true. I have to admit, over the years of me doing this, it's funny. You'll see. I've worked in the Deep South before, where there's a lot of people that smoke and don't drink, and there's a lot of coronary disease there, believe it or not. And I've met siblings that have obviously genetic similarities, and one will have bad coronary disease and doesn't drink, and the other one has some red wine in the evening and doesn't have any coronary disease. So it's funny. You'll see that kind of these examples are they're individual examples, but over time you really do get
you get that generalization,
that general feeling that there's probably a lot of truth to this. So
I'm going.
There you go. Now you know what to do.
I'm stopping at the store.
You need to stop at Whole Foods or Publix on the way home.
I'm getting some dark chocolate.
That's right. Now that Whole Foods is a lot cheaper.
Well, I already had the red wine. Oh, that's excellent. So, I'm just taking a look at some notes here that I've been given, and it's correct to assume that you treat the heart conditions and lung conditions as well?
That's right.
Okay, share with us, please.
Well, my main focus of interest is doing minimal access open heart surgery, basically. And what we mean by that is making small incisions on the chest rather than, going through the sternum.
Really?
And so that's kind of my main interest. And we do a lot of valve work that way, or I do, and a lot of treating arrhythmias like atrial fibrillation that way. And and so working with other cardiologists, we have a very specific game plan for each individual patient, and so, but that's what I really try to focus on.
Well, that's really quite state of the art. Now, you do that through a specific type of machine?
Well, we use small incisions, and there's a lot of very special equipment that goes with it. There's a small, very specially designed retractors, specially designed instruments. We use a small, camera that has a light on the tips and those kind of things.
Okay.
And there's special, cannulas that we use to get people on bypass. So there's a lot of, you really have to shift your thought process, your mindset when you're doing mini access heart surgery versus doing it through a sternotomy, and the benefits of it is that patients don't require as much blood. Our percent a chance of getting blood after undergoing a mini access surgery is much lower than if you went through a big open operation, and people get out of the hospital a little bit faster. And they recover faster, and so those are kind of the benefits we see.
Usually what you had seen was that you were opening up the whole chest cavity.
Right.
And did you have to then open up the rib cage as well to be able to get to the heart?
Well, when you go through the sternum, you just, you put a retractor in, and, you're right in the middle of the chest and looking down on the heart. And, when you close that up, you have to put wires in. And, sometimes people get infections in those areas, and so that's another benefit of doing it through a small access incision. So
that's fabulous.
Yeah. It's very satisfying when you see how well the patients do, and that they they're back on their feet pretty quickly. So
that is absolutely wonderful.
Yeah.
So, and you work with the lungs as well?
Yeah, we do some lung surgery. So people that come in with lung tumors. And pleural-based diseases is what we call that, around the lung. We do surgery for that as well. We try to do them through small incision surgery as well. So
that's fabulous.
Yeah.
So, doctor, how do they get a hold of you?
Yeah, that's a good question. Yeah, you can look me up online. That's probably the easiest thing. If you just Google, Erik Beyer, Florida Medical Center.
That's spelled Beyer.
That's right, Erik, and then Beyer, Florida Medical Center.
Okay.
And there's a web page there, and it has all the information, including phone numbers and contacts and those kind of things.
And what insurance you take as well.
We pretty much take everybody.
Good.
There was a time where Humana, there was an issue with Humana, but now they're back on board.
Are they?
So,
Okay.
So
Good.
we're all squared away. So there's not really a lot of insurance issues there.
Great. And what's your telephone number?
You would ask that. I'd have to look that up. My office number, but I'll give people my cell phone number. Believe it or not, as crazy as that sounds, I've done this before, and I'm going to do it on the air.
Are you?
But
okay. Wait a minute. Let's set this up.
No, this is my cell phone, personal cell phone.
Personal cell phone.
Yeah.
I have got to tell you, I have never in my life heard of a doctor giving his personal cell phone.
Yeah, and I've done it to pretty much all the patients I operate on. Get my cell phone actually, and
wow.
Yeah, so I'm gonna do that on air here. It's 786-202-3531. And then obviously there's if I don't answer if I'm in surgery or something like that, then it'll go to an answering service. So then you get a hold of me that way.
Oh my gosh, that's I just want to say thank you.
I love doing this so much, and I love taking care of patients so much that it's something that interests me, and we love talking to patients as well. So. Get their problems fixed.
Oh, my goodness.
And if we can't do it, we'll get them in the right direction.
Well, that is absolutely wonderful. I'm totally amazed.
Yeah.
Thank you, All County Healthcare, for sponsoring this show so that we can bring on these type of doctors for you. Because I've got to tell you, there's nothing better than someone, first of all, giving out their cell phone, their personal cell phone, but that cares so much about the well-being of his patients and the things that he can help with. And also, even if you're not the right fit or you need something different, he would be there to help you as well.
Many, many doctors in our network that, like I said, whether it's a cardiologist or an electrophysiologist or interventional cardiologist or a structural heart cardiologist, there's a lot of options out there, and we can get you moved in the right direction, that's for sure.
That's incredible. Well, thank you for that.
Anytime.
Now, I was also, there's a procedure called the maze procedure,
Yeah.
MAZE.
Yes.
Can you explain that to us?
Yeah, that's a great question. I don't know if we have enough time to explain it, but
Or give us
I've given the synopsis so many times in my life. I think I can probably break it down. Atrial fibrillation is the disease process we're treating with the MAZE procedure.
Okay.
And so there's a lot of people out there with atrial fibrillation.
Describe that just a little bit, just in case our audience might be experiencing that and they don't know what it is.
I'll describe that to you. In fact, I have a YouTube channel that, if you ever wanted to look at some of the surgery videos that we do, including the MAZE procedure, is on there, and I'm constantly updating it. So, you can subscribe to that YouTube channel. But what it is AFib is when the heart is not in sync rhythm-wise.
Oh, okay.
And so people will sometimes experience it as a very fast heart rate with a lot of, deep palpitations. Some people may not notice at all that they're in AFib, and they're just kind of chronically fatigued and short of breath and dizzy. And then, of course, the worst thing that can happen to you when you have AFib is that you have a stroke, and you didn't know you were in AFib until you've had that stroke. And so AFib is when the top two chambers of the heart quiver. They just quiver. There's not a coordinated beat, it should be coordinated. Everything should contract in unison and relax. And AFib, the two upper chambers are just kind of quivering. And then that sends some weird signals to the lower chambers of the heart, the ventricle. And so people will get these weird, irregular beats. And the way we treat it is by addressing the atrium, obviously the two upper chambers of the heart.
Right.
And we go in, and there are a lot of options. And it's very confusing. If you were to ever go online, I imagine it would be very, very confusing world because cardiologists can treat this. And the surgeons can treat it. And typically, an electrophysiologist like Dr. Kenningsberg, the one electrophysiologist I mentioned, or Dr. Nayari, they are the ones that kind of address this problem initially. And if they have trouble treating it, then they would approach me. And then we have a way of fixing it, which is the MAZE procedure.
Okay.
And it's the gold standard of treating this problem. There was a gentleman named Jimmy Cox out of St. Louis. He's retired now. He designed this procedure in the lab, basically, and then he started doing it on patients, and they found that he was getting awesome results. He was curing atrial fibrillation.
Wow.
So, but it was a very difficult procedure to do, and you had to go through the sternum, and so not a lot of people, ended up doing that. And then over the years, over the decades, we've figured out kind of maybe where to pinpoint the disease, and sometimes it's not, you have to undergo the MAZE. And we have new devices now that we can go through small access, like I was talking about, incisions. And what we do is we kind of create a maze on the heart, believe it or not. We create scars on the atrium so that the electrical impulse will follow that maze, believe it or not. Yeah,
really?
And that's why they call it the MAZE procedure, because if you were to draw it out, it almost looks like a maze. And so a lot of people added Jimmy Cox's name to it, so they got the Cox MAZE procedure, and so that's why it's called that. And there's a lot of iterations of it, so it can be a very confusing world for patients that have AFib.
Oh, absolutely.
Yeah.
Absolutely, and very much scary too.
That's
I would
right.
imagine.
That's right.
Because sometimes you just don't know what in the world is going on and why this is happening, and it can be a little
it can be daunting. It can be daunting, no doubt about it.
Well, and what is September then? Also,
I know. What is September?
September. It's Atrial Fibrillation Awareness Month.
Is that right?
Yes.
I did not know that. They keep coming up with these things. I know. The heart disease month is February, but I did not know that. That's interesting.
Yeah.
So it's actually I operated on a lady, and I'm sure she doesn't mind me telling you. Her name's Melanie Truehills. And she started a website called stopafib.org. And that's a great resource, actually, to go to. But I actually operated on her, I think it's over 10 years now ago. And she's been in normal rhythm ever since. And and she was so excited about it, she actually started a website and is on speaker bureaus everywhere. And she's got some great resources there, too.
It sounds like you've got your own PR person there, huh?
I do indeed. So look that up.
That is great. Now, give us a little bit of information about the hybrid convergent procedure.
Yeah, again, this is where I was saying it gets a little confusing.
Okay.
The Cox maze is a procedure that we tailor sometimes to some patients, and then there's another procedure called the convergent procedure where it's a combination of the electrophysiologist and the surgeon doing the procedure. And basically, this is a hybrid approach to treating this problem and addressing issues with AFib, and it has a fairly high success rate too. It's not as high as the Cox Maze 4, but it's a little less traumatic to patients, and so we're trading off success for less trauma to the patient and faster recovery time. But we're starting to see very good results with this. And so basically, there's a small incision that's made underneath the sternum.
Oh, okay.
And we go in and ablate or cause the scar tissue to the back wall of the atrium, which is where a lot of the AFib seems to be generated from. And so that's another way to treat this issue too. And again, we tailor the procedure individually to the patients.
Excellent.
Yeah.
Excellent. That's great to know.
That's important thing, because you want somebody that can do everything.
Yeah, absolutely.
And we go from just transcatheter ablation all the way to doing the Cox Maze 4 through small access surgery. So we have the whole gambit.
That is awesome.
Yeah.
Well, I've got to tell you, it has been a pleasure. I'm just double checking here and make sure that I know what else I want to ask you about. VATS. VATS. What does that stand for?
That stands for video assisted thoracoscopic surgery. So that's also what we're talking about, doing small access surgery on the lung. So it's with a video scope, and it's assisting you to do the surgery on the lung. And so that allows us to do smaller incisions, and we can even remove lobes of the lung through these kind of small incisions for lung cancer, lung tumors.
Ooh, goodness. So give our audience some preventive ideas on what to do, what not to do when it comes to your heart.
Yeah. Obviously the biggest thing I think you could do is don't smoke. I hate to say it, but I know a lot of people are out there that are they really enjoy their cigarettes, and I tell people I don't try to lecture smokers, because it really doesn't go anywhere lecturing people. I think it's about giving them knowledge and understanding about what they're doing to their health. And and to be honest with you, my mother smoked in the past, my dad smoked in the past. Back in the 70s, it was quite fashionable, I think, to
in the
smoke.
60s.
In the 60s, for sure.
Yes.
And I even remember seeing some commercials where some doctors were saying, after surgery they like to have a smoke, And so, but what we realized over time. And Michael DeBakey, actually, who's now is one of the famous heart surgeons from Houston, who's no longer with us, obviously, but he was the one that helped figure out that lung cancer came from smoking. But also we found out since then, peripheral vascular disease, coronary artery disease, carotid artery disease, all of that is certainly aneurysms of the abdominal aorta, thoracic aorta. All those are certainly related to smoking. And so, it's important to realize that that's very important, not to getting some exercise, even if it's just getting out to walk, 10, 15 minutes a day is a good idea. And try to eat those antioxidants that we talked about. And they're in a lot of foods. They're in vegetables. They're in, in some fruits. And so that's why it's important.
Dark chocolate.
Dark chocolate. You want to kind of bombard your body through the day with these antioxidants. I think they're very helpful. And so I think that's how you eat and exercise and try not to smoke, I think, would be the most important thing.
And I just want to ask a little bit more, because the big thing now is vaping.
Yeah.
What do you see versus regular cigarettes versus vaping?
I think the jury's out on that. My general impression is that if you had to pick one, if you're forced to pick one, I think vaping probably would end up being better. But I don't know. Maybe in 10 years' time, I'll look back at this conversation and say, "Well, I was wrong." But I think it's not
healthy.
well understood.
Well, that's true.
And we don't have the results yet of because people haven't been vaping that long, and time will tell how bad it is. But I probably would err on the side of caution there and just avoid being
just
addicted
don't
to
smoke
nicotine.
at all.
Nicotine is extremely addictive. There's no doubt about it, and it's very pleasing to your mind. That's why people do it. They don't do it because they're wanting to make their family members mad. They're doing it because it relaxes them and it gives them a sense of ease and peace. And so there's a very strong addiction component to this, obviously,
right.
And so understanding that and understanding your the weakness to that is important part of learning how to stop smoking.
Yes, absolutely. Yeah. I completely agree.
Yeah. I was watching House of Cards, I was catching up. Well, that show. Have you ever watched it? There,
a little bit. Yes.
And Kevin Spacey's always, he's a politician in there, and they also have a smoke at the end of the evening and relax, And so you can really get in the mindset of a smoker, and understand why they do that. And it's killing you, literally killing you.
It is. Yes, absolutely. Well, I cannot thank you enough for being on our show tonight.
Yeah.
Because I do know how busy you are and that you took time out to come and help educate us, teach us about your particular expertise.
Yeah, it's my pleasure. Absolutely my pleasure.
Which I've heard you're the greatest at. Okay. And if you want to get a hold of Dr. Beyer, please give him a call at FMC or go on the website at FMC and ask for him. And if that doesn't work, you can always call All County Healthcare. Ask for Maddie, and she's at 888-717-7170, and she'll put you in touch with the doctor as well. So thank you again for being here. We so appreciate it.
Thanks.
And we're going to go on a commercial. Stay tuned. Do not leave. We got another doctor coming.
All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision and only your decision on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096.
Getting older is not for sissies. That's what one of my patients says. And it's funny, but it's true. Live long enough and you'll get arthritis, skin cancer, probably one of the common chronic diseases like CHF, COPD, diabetes. At All County Healthcare, we teach you how to manage your disease. We make sure you know how to take your medications and how to recognize signs and symptoms before requiring hospitalization, no matter how many visits it takes. You didn't move to Florida to be sick. You moved here to enjoy the rest of your life. And that's exactly what our team of nurses, therapists, and aides at All County Healthcare help you do.
You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
Hi, welcome back to You and Your Doctor, where we're teaching you how to live a healthier and longer life. And just a little note out to our friends in Texas. We send prayers and thoughts to you and speedy recovery, hoping that everything gets cleaned up real quick, and you have the ability of getting back on your feet and back to living life the way you knew it to be. So we're here with another wonderful doctor. He happens to be a plastic surgeon. His name is Dr. Hilton Becker, and he's got some very, very interesting information for us. So welcome, Dr. Becker. It's wonderful to have you here.
Thank you.
Thanks for taking time out and being with us.
My pleasure.
So tell me, when did you decide that being a doctor was something in your blood, that you had a passion for it?
Well, I've always been interested in physical things, mechanics. I did physics and chemistry in pre-med, and I was leaning towards engineering.
Well, okay. Well, engineering of the body.
Exactly. So I started medicine, and I realized that there was quite a lot of engineering in medicine, especially in surgery. So I drifted into surgery. Then I saw what the plastic surgeons were doing, and I thought, that's just for me.
Excellent.
So I started plastic surgery.
So, and where did you do your schooling?
Well, I trained in South Africa. I did my basic medical training there.
I was hearing an accent,
Yes.
So that's why I was wondering.
So I did my basic medical training in South Africa. I did my general surgery and my plastic surgery. I then did a second residency in the United States at the Medical College of Virginia. So I've done 2 plastic surgery residencies.
Excellent.
Yeah.
Wow, that's fabulous. Well, we were talking a little bit beforehand, and you were saying that you've seen some remarkable things happening in plastic surgery. Give us a little bit of an idea. First of all, what it used to be, and then its evolution.
Well, I think there's several areas I can describe. I think one of the biggest things we've seen is now in the era of minimally invasive surgery.
Yes.
So I'll give you 2 examples. When I started my training, if a young girl came in for a breast reduction, for example, she would have been admitted to the hospital a day before surgery. She would have been typed and cross-matched for 2 units of blood. She would have had 4 to 6 hours of surgery.
Oh, my goodness.
She would have stayed in hospital for 3 to 4 days. She would have had massive scarring, what we call the anchor scar.
Right, I'm
right
familiar.
around all the way horizontal. Today, a breast reduction is done under twilight anesthesia. The patient goes home the same day. The scars are very minimal. They can be what we call the lollipop scar.
Okay.
Which looks like a lollipop.
Right.
Sometimes even just a circular scar.
Wow.
So totally different. And the surgery time is 2 hours compared to 4 to 6.
Oh, my goodness. That's huge.
Yeah.
That's
and
quite a...
very little bleeding, very little loss of blood. Another area which I do a lot of work in is in breast reconstruction.
Okay.
Breast reconstruction, when I was a general surgery resident, breast reconstruction was not done. Surgeons were doing radical mastectomies. They were literally mutilating the patients, cutting off the whole breast, cutting off the muscle, putting on a skin flap, and there was no reconstruction done.
Wow.
Today, we can do a breast reconstruction where we save the whole nipple areola complex. We can put the scar underneath the breast where it's hidden. The patient can have a mastectomy and a reconstruction all done in one operation, where the patient can come out looking better than she did before the mastectomy.
Oh, my goodness.
So major changes.
That is major. Right. That's absolutely amazing. And especially with the breast reduction, because there are so many women out there that unfortunately are very overdeveloped, and it just is so difficult for them. Back aches, neck aches, where the bra is digging into their shoulder, and I would imagine that this kind of reconstruction is just absolutely fabulous for them.
Yeah. Well, patients who've had a breast reduction often say they feel like a bird that's been let out of a cage. They can now fly, literally fly. Because, could you imagine walking around with 2 watermelons tied around your neck?
Oh, my God.
And women suffer through life like that.
Yes.
Where today it's not necessary.
Oh, that is so wonderful.
Yeah.
How long have you been in practice?
Just over 30 years.
Really?
Yes.
Wow. So you have seen a lot of the evolution. My goodness. So on reconstruction for cancer patients, explain to us, what some of the procedures are. Give us some insight as to what is available for them, especially if they have to lose all of the breast tissue.
Yeah. Well, there are several procedures available. You can use your own tissue, which is called autologous reconstruction. That involves moving tissue from one part of the body to another. It can be done as a flap, where the tissues are attached, or it can be done as what's called a free flap, where the tissue is actually cut off and the vessels are reanastomosed. Tissue can be taken from the abdomen, from the buttock, from the thigh, etc.
Okay.
That's a fairly big operation, but it eliminates the need for a prosthesis. On the other hand, you can use a prosthesis. The way I do it is I use an adjustable breast implant that is placed initially underfilled or even empty if necessary, so that the patient has a mastectomy. Immediately after the mastectomy, it looks like no reconstruction was done. Because we wait for the circulation to pick up, make sure that the wound's going to heal, and then we fill the implant after surgery with saline injections.
Oh, okay.
Another change is that we now put the implant above the muscle instead of below.
Oh.
And I do that for all my breast surgeries today, including cosmetic breast augmentation and the reconstructions. Because if an implant is placed beneath the muscle, patients get what's called animation deformity. When they contract the muscle, the implant distorts and moves.
Right.
It also causes pressure and pain. We've learned over the years that if we put the implant above the muscle, they don't have this animation deformity. They don't have the pain, they don't have the discomfort. So I do a lot of revision cases on patients who in the past, either augmentation or reconstruction, have had the implants under the muscle. We convert them to above the muscle.
That's really interesting, because I remember when they first came out, it was above the muscle.
Yes.
And then it made a very strange indentation in the chest cavity, especially when, you would have a level of cleavage. So it left like an indentation. So you're able to come away from that?
Well, what you said, initially it was above the muscle, and then they moved to behind the muscle, because they thought it was safer and would reduce the incidence of capsular contracture. They've now found that if you go above the muscle, as long as you elevate the layer of the muscle that's called the fascia, which is the lining of the muscle, if you elevate that, that gives you sufficient support for the implant. And you don't need to go under the muscle. Now, another thing we do in breast reconstruction today is if we don't have a thick enough coverage over the implant, instead of going under the muscle, we inject fat into the skin flap.
Wow.
So we harvest fat from the abdomen and inject the fat. There have been some major advances in fat injection. Fat injection is not really new.
Yes, tell us about that.
It's been done for a long time, but over the years we've learned how to improve this technique. For example, what we've learned is when you harvest fat, you break some of the fat cells down. The fat liberates oil, and you have dead cell components, and this interferes with the survival of the fat. So if you can clean the fat very well, get rid of the oil, get rid of the dead cells, the fat will survive better. We've also learned how to harvest the fat less traumatically, how to inject it less traumatically. And what I'm doing today is I'm using PRP, which is platelet-rich plasma.
Okay.
And what platelet-rich plasma is, it's blood that we harvest from the patient. We take out the red cells and we concentrate the platelets. The platelets have the growth factors, which stimulates the tissue and helps it survive, and also stimulates collagen formation. Fat cells also have what's called stromal vascular fraction, which is the connective tissue of the fat. So we've learned today how to harvest that portion of the fat which contains the stromal vascular fraction, which also contains the stem cells.
Excellent.
So the stem cells are the rejuvenating cells.
Right.
So when you inject stem cells, for example, into the face, it rejuvenates the skin. So we can harvest fat, we can concentrate the stem cells, we can concentrate the platelets, now injected into the face, often taking place of a facelift. And in the face, we can inject the forehead, the upper lids, the cheeks, the chin, the whole face. So we're doing much less facelift surgery compared to what we were doing in the past. We're doing filling surgery. So I've drifted off the breast reconstruction for a moment.
But that's all good knowledge. That's amazing knowledge.
So coming back to the breast reconstruction, now with the tools of the stem cells and the PRP, we can enhance our fat survival. So we can thicken the flaps with less need to bring flaps in from other areas of the body. We can thicken the flap that is left behind by the general surgeon, which makes the reconstruction much easier.
Wow, that is absolutely amazing. Yeah. I love hearing about that. That's incredible. Now, with the fat harvesting, is it just a clump, or do you mold the fat, or how does that work?
Well, the harvesting is done exactly the same way as liposuction.
Okay.
So we do liposuction, but instead of throwing the fat away, we save the fat. I always say fat is a terrible thing to waste because it is so useful in the body. Instead of throwing it away, you can salvage it and utilize the various components in the fat to do a whole lot of things. I told you with the face.
Yes.
We can inject it in the breast, even in patients having a breast augmentation to give a better contour, a better shape.
And does the fat stay then in that space?
The fat stays where we inject it.
Wow.
The fat is injected with a syringe, just with a needle. The same as the various fillers, like Restylane or Radies. You can put fat into a 1 cc syringe and inject it very much the same way. So you can rejuvenate the face. You can fill the breasts. You can even, in certain patients, you don't even need to do a breast implant. You can get a small breast just with fat injections alone.
That is amazing. That is really incredible. And so the fat stays in that particular area that you put it in, and does it ever go away?
No.
Or because sometimes, when I'm losing weight, the fat goes away. When I gain weight, the fat comes back. So
we like to get the fat from the areas where it doesn't go away.
Yeah, okay.
Right.
Yeah.
So it's the hip roll.
Yes.
The saddlebags,
abdomen.
Saddlebags and the abdomen.
Yes.
So we salvage the fat that really doesn't go away. Now, the fat doesn't all survive, so you may need to have it repeated.
Okay.
Maybe a few times until you get the desired effect. Okay,
excellent. Yeah. And, I've also heard of the fat being injected into the buttocks as well.
Exactly.
To plump that back up again.
Yes, exactly. You can. So if a woman has a lot of excess fat on the abdomen, you can harvest that fat, inject it into the buttock. Yeah.
Love that. Now, do you have to allow it to sit for a while it is being harvested, or can it go right back in?
No, the sooner you get it back, the better.
Okay.
Because remember, the fat that is injected has now lost its blood supply. So the fat, provided it's a small enough particle, will be able to survive for a while through the body fluids that it's sitting in. And then blood vessels will slowly grow into the fat to re-nourish it. That's where the PRP comes in. The PRP has factors that stimulate blood growth called angioplastic growth factors.
Okay.
Stimulates the blood vessels to grow back into the fat and keep it alive.
Wow, that is very fascinating. Yeah. And that's great to hear because, what I've heard a lot of times, when you go in for the injectables, you're right. It's just like Juvederm or Restylane or the various fillers. Yeah. And now you're using the PRP along with that. And then I know a question. Is it better to use the injectables with the PRP or the fat rejuvenation in the face? Or do you use that in combination?
Well, I give the patients the option. Of course, the off-the-shelf injectables, you just pick up the syringe and inject and it's done. The fat, you've got to harvest the fat. So it's an extra procedure for the patient. You've got to numb up the area. You then got to aspirate the fat. You got to process it. You got to get the PRP and mix it with the fat and inject it. So it's a more timely procedure, takes more effort to do. It's not just taking a syringe and injecting it.
Gotcha.
But the other thing is that most of the injectables are not permanent. Now, there are
That's
some,
what I was going to say,
now,
too. Yeah.
there are some permanent ones, but people are reluctant to use the permanent because what if they don't like it? The permanent ones are difficult to then remove.
Right.
Now, the fat is permanent, but it's natural tissue. It's not a foreign body sitting in there like silicone. Silicone injections are permanent. But if you don't like it, it's difficult to get rid of, and it's a foreign body.
Right. That's fascinating information. That is wonderful. So even with breast augmentation, you can use your own fat cells as well.
Correct. So, as I said, you can create a breast with no implant, but a limited size. You can't make it very big. But what we also do when we do an implant, sometimes, as you mentioned, you have an irregular surface on the implant or a dent. So you can combine the fat injections with the implant, which gives a very nice, natural, smooth shape to the breast.
Wow, that's fabulous, because I do remember way back when they first were introduced, and how there was, as you said, the dent in the breast area, and that's how you almost always knew, or they were as hard as rocks.
Correct.
That was another thing, yes.
Well, that was another thing, because the old silicone implants used to leak silicone oil. And the silicone oil caused an inflammatory reaction, which caused what's called capsular contracture, that's hardening around the implants.
Okay, great.
And
I was going to ask you to explain that to us, because some of the audience members might not understand what the capsular is. That you can explain.
Right. Well, capsular contracture is not the implant; it's the body's reaction, usually to an irritant around the implant. Now, it could be the silicone that oozes out of the implant, or it could be low-grade infection. Now, the old implant, which had the silicone oozing out, has now been replaced by what's called a cohesive gel, and it looks like a gummy bear. So some people call it the gummy bear implant. So this is almost a semi-solid implant. So there's minimal oozing, virtually no oozing out of this implant. So you don't get as much capsular contracture as we used to see in the past.
That's fabulous. So, and the other thing too, that there was a lot of lawsuits that came about because of the silicone leaking within the body.
Correct.
Do you see any more of that happening?
No, because they've now changed it to the cohesive gel, the gummy bear.
Okay.
And also all these alleged illnesses that silicone was supposed to cause, medical literature has refuted most of that. I mean, there's no real evidence that silicone causes these autoimmune diseases. Because silicone is actually...
very interesting.
Silicone is found in a lot of things. Every syringe is lubricated with silicone. The plunger, the needles are lubricated or coated with silicone. A lot of other implants are silicone. The doctor you just had on with the pacemakers are coated with silicone. Brain shunts are silicone. A lot of joints are silicone.
That's very interesting. I did not know that.
And the FDA has approved silicone injections into the face. So silicone is very, very non-reactive in the body.
Okay.
But having said that, we do still have saline implants, and a lot of patients want and like saline implants. There is a new saline implant out at the moment, which I'm using as well. It's called the Ideal implant. And what it is, it's a saline implant that has extra chambers within, made out of solid silicone. So an implant is made out of a shell. So they've put extra shells inside the shell, which baffles the saline. So it's almost like the old water beds. You remember the old water beds were ripply and they put foam inside?
Yes.
So this is similar. So we now have a saline implant that feels more like a silicone gel implant. So for patients that don't want silicone and are reluctant to have saline, they can have this new implant, which so far I've used quite a few of them and they look very encouraging.
That sounds incredible. Yeah, because I was going to ask you the difference between those two. I had somebody tell me that they had saline implants, and it was almost like you could hear the water swishing.
Correct. Correct.
And I'm like, uh-oh. Or another one ended up bursting.
Yes, and then suddenly goes flat.
Yeah,
Right.
like a flat tire almost.
Right.
So
that's why these newest saline implants are very encouraging, because they have the multiple chambers. They have less squishing of the saline. They feel more like silicone and less likelihood to leak suddenly.
That's incredible. So if you're doing reconstruction and you're using the saline
Adjustable implant, yes.
the adjustable, do you recommend that after they reach that particular size that they're looking for, that they swap out for a different...
Well, that's the beauty of the adjustable implant. They don't have to. The adjustable implant has a little filling port attached to it, which is buried under the skin, and that's how you access it. The needle goes through the skin into the port, so you can increase or decrease the size to where you want it. Once you've reached the right size, a small incision is made over the injection port. The injection port is removed with 1 or 2 little stitches, and then the patient is done. But at that stage, she has a saline implant.
Gotcha.
Now, if her tissues are very thin and she has some rippling, she can switch it out to a silicone implant instead of the saline.
Okay.
So she's not committed to the saline, but she's not committed to having to remove it like a tissue expander. If a patient uses a tissue expander, that has to come out. It cannot stay in.
It can't stay in.
Right.
Yes. With that being said, also, with those individuals that have the ports and the saline implants, do you find that a lot of times as the age goes on and the skin starts to stretch even more, that it's very easy to put more water or more saline into the implant?
Well, no, with the adjustable, once you pull the injection port out, you cannot put more in.
Okay.
That's it.
Okay.
But you brought up an interesting point. As women get older, they now don't want the implants anymore.
Really?
Yeah. So we see older women who come in and they say, I've had my implants for 30 years. I'm tired of them. They've got a little firm. I want them out. What can I do?
Wow.
So they have quite a few choices today. It's not just rip the implant out and leave them with skin bags that are just hanging.
Right.
We can take the implants out. We can inject what's remaining with fat. And leave them with a small, normal, natural breast without an implant. We can rearrange the tissues, bring in tissues from the side and from the bottom to give more fullness, even without an implant. Or we can do what we call a mastopexy, a breast lift. So we can take the remaining tissues, rearrange it, give them a smaller, lifted breast. So when they remove the implants, they're not left deformed.
That's what I was wondering, because, you're right. As we start aging, that skin begins to continue to stretch.
Stretch and sag,
and, yes. And also with aging, the skin is not elastic anymore. Right. So it really doesn't bounce back the way that it would normally, bounce back when you were younger.
Exactly.
So that's very interesting. That's good to know. But I'm surprised that a lot of the older women would prefer to remove the implant and not have it any longer.
Yeah. Well, especially the ones who've had the older implants that have become hard and firm. They want them out. But, the other thing with a lot of women, as they get older, their breasts get bigger. And now they've got the implant and the increase in size, and they want to be smaller. So instead of doing a breast reduction, we just take the implants out, rearrange the tissue, and they look much better.
Now, one final question. Does insurance pay for the fat injections if you're doing reconstruction of...
Yes.
Okay.
Insurance will pay for breast reconstruction after a mastectomy.
Okay.
Irrespective of what technique you use. If you're going to use fat injections, or a tissue expander, or a flap, or an implant, or even a revision. If you have a complication or you have asymmetry, they will also pay for a symmetry procedure of the opposite breast. For example, if a woman has a mastectomy, she has a very large breast on the other side, they will pay for the reduction on the other side, or even a lift on the other side.
Wow. Well, that's great to know.
Yeah.
That's great to know. It has been an absolute pleasure. How do people get a hold of you, Dr. Becker?
Well, they can reach me at my website,
Okay.
www.beckermd.com.
Okay.
They can call me on my phone, 561-394-6656.
Okay. Now, one more time and just a little slower in case they're running for a pen and paper.
561-394-6656.
Okay.
They can also call West Boca Medical Center, who will give them my phone number or my website. My website is www.beckermd.com.
Okay, that sounds great. And if you do have any questions for Dr. Becker, you can also call All County Healthcare, ask for Maddie. That telephone number is 888-717-7170, and she'll put you in contact with the doctor. Well, it has been absolutely wonderful to have you here. Thank you so very much.
Thank you very much. Nice to see you.
And that's all for this show on Tuesday, the 29th of August. We look forward to seeing you next week, Tuesday, from the hours of 6 to 7. I'm Lorena Anderson. Thank you so much for being with us tonight.